I'm Dr. Robert Hayes, Chief of Neurosurgery at St. Catherine's Medical Center in Portland, Oregon. Or at least, I held that position until I submitted my resignation 3 weeks ago, effective immediately. After 22 years of practice and over 4,000 successful surgeries, I walked away from everything I'd built. I earned my medical degree from Johns Hopkins, completed my residency at Massachusetts General, and spent 2 years in fellowship training at the Barrow Neurological Institute. I've published 47 peer-reviewed papers on complex spinal tumor removal and cranial reconstructive procedures. My colleagues considered me one of the most technically precise neurosurgeons on the West Coast. The American Association of Neurological Surgeons awarded me their Excellence in Surgery recognition 3 consecutive years. I have seen everything you can imagine in neurosurgery. Tumors wrapped around brain stems like malignant vines, aneurysms ready to rupture at the slightest touch, traumatic injuries that turn human skulls into jigsaw puzzles. I've operated on newborns whose heads could fit in my palm, and 90-year-old veterans whose brains had been ravaged by decades of silent strokes. I've saved lives, lost patients, and made peace with the razor-thin line between medical miracle and tragic failure. But what I'm about to tell you is the one case that shattered everything I thought I knew about human physiology and ultimately drove me from the profession I devoted my entire adult life to mastering. St. Catherine's is a level 1 trauma center with a 12-bed neurosurgical ICU and 4 dedicated operating suites. The hospital's neurosurgery department handles approximately 800 major cases annually, from routine disc removals to complex craniotomies. Our team includes 6 attending surgeons, 14 residents, and some of the most advanced surgical equipment on the West Coast. The Carl Zeiss O-PM Pentero 900 microscope in OR7, where I perform most of my procedures, provides magnification up to 40 times normal vision with integrated fluorescence capabilities. October 15th, 2024, started like any Tuesday. I arrived at 5:30 a.m. for pre-surgical rounds, reviewing cases scheduled for the day. 3 routine procedures: a lumbar discectomy on a 45-year-old contractor, removal of a benign meningioma from a 60-year-old teacher, and what appeared to be a straightforward craniotomy to address increased intracranial pressure in a 28-year-old woman named Patricia Brennan. Patricia had been transferred from Good Samaritan Hospital in Bend after presenting with severe headaches, visual disturbances, and episodes of altered consciousness. Her initial CT scans showed signs of elevated intracranial pressure, but the cause remained unclear. Dr. Amanda Fisher, our chief resident, had admitted her at 11:47 p.m. the previous night after a more detailed MRI revealed what appeared to be a small, well-defined mass in the left temporal lobe. I reviewed Patricia's films that morning in the reading room adjacent to OR7. The mass measured approximately 2.3 centimeters in diameter, located 4.7 centimeters posterior to the temporal pole and 3.2 centimeters superior to the middle temporal gyrus. The imaging characteristics suggested either a small glioma or possibly an unusual presentation of a cavernous malformation. The contrast enhancement pattern was atypical. Too uniform for most gliomas, yet too irregular for a typical cavernous angioma. Patricia's medical history was unremarkable. No previous surgeries, no significant illnesses, no medications except occasional ibuprofen for headaches that had begun 6 months earlier. She worked as a graphic designer, lived alone, and had no family history of neurological disorders. Her neurological examination was normal, except for mild photophobia and slightly delayed response to complex verbal commands. Surgery was scheduled for 1:30 p.m. I spent the morning completing the lumbar discectomy, which proceeded without complications, finishing at 12:15 p.m. After a brief lunch, I reviewed Patricia's case once more with Dr. Fisher and my scrub nurse, Jennifer Walsh, who had assisted me on over 300 procedures during her 8 years at St. Catharines. At 1:25 p.m., Patricia was wheeled into OR 7, already under general anesthesia administered by Dr. Kyle Morrison, our senior anesthesiologist. Her vital signs were stable. Blood pressure 118/76, heart rate 72 beats per minute, oxygen saturation 99%. Dr. Morrison had been providing anesthesia for neurological procedures for 15 years and was known for his meticulous attention to detail and precise medication management. The positioning and preparation proceeded normally. Patricia was placed in the left lateral decubitus position with her head secured in a 3-point Mayfield clamp. The surgical site was prepared with chlorhexidine solution and draped according to standard sterile protocol. I marked the incision line based on the preoperative imaging, planning a small craniotomy approximately 5 centimeters in diameter centered over the mass location. At 1:58 p.m., I made the initial scalp incision. The tissue planes separated normally, revealing the temporalis muscle and underlying bone. Using the Midas Rex drill system, I created the bone flap, removing it to expose the dura mater. Everything proceeded exactly as I expected for the first 47 minutes of the procedure. At 2:45 p.m., I opened the dura with microscissors, revealing the brain surface beneath. The gyral pattern appeared normal, with no obvious surface abnormalities or discoloration. Using the pentero microscope at 10 times magnification, I began carefully dissecting toward the mass location, following the planned surgical corridor. This is where everything changed. As I approached the area where the mass should have been located, approximately 4.2 centimeters from the surface, I encountered something that defied every principle of neurosurgery I'd learned in 2 decades of practice. Instead of the expected tumor tissue, I found what appeared to be a perfectly formed miniature anatomical structure that had no business existing in the human brain. It was a small translucent chamber, roughly spherical in shape, measuring approximately 1.8 centimeters in diameter. The walls appeared to be composed of tissue that resembled a neural tissue, but with an organization I'd never seen before. Most impossibly, the chamber contained what looked like clear fluid that moved in slow rhythmic patterns, as if following some form of circulation system. "Jennifer, are you seeing this?" I asked my scrub nurse, who was monitoring the surgery through the microscope's secondary eyepiece system. "Dr. Hayes, what exactly am I looking at?" she replied, her voice carrying an uncertainty I'd never heard from her before. I increased the magnification to 25 times. The structure became even more bewildering. The walls of the chamber showed what appeared to be organized cellular patterns, but they didn't match any known brain tissue architecture. The fluid inside continued its strange pulsatile movement, and I could now see tiny hair-like structures extending from the inner walls into the fluid space. "Dr. Morrison, are you getting good neuromonitoring signals?" I called to the anesthesiologist. "All monitoring is normal, Dr. Hayes. ICP remains stable. No changes in any parameters," he responded. The intracranial pressure monitoring showed readings of 12 millimeters of mercury, well within normal limits. I gently probed the structure with a blunt dissector. It yielded slightly to pressure but maintained its shape. Most disturbingly, when I touched it, the fluid movement inside accelerated noticeably, and I observed what appeared to be electrical activity across the chamber walls. Tiny lightning-like discharges that definitely should not exist in any known biological tissue. Dr. Fisher, who had been monitoring the procedure from the observation gallery, came down to the OR floor. "Dr. Hayes, the preoperative imaging showed a typical mass lesion. This structure, it doesn't match anything on the MRI." She was right. I had the preoperative films pulled up on the OR display screen. The mass we'd seen on imaging bore no resemblance to what we were looking at now. The MRI had shown a relatively dense, homogeneous lesion with typical contrast enhancement. This translucent, fluid-filled chamber should have appeared completely different on imaging. I made the decision to take a biopsy sample from the chamber wall. Using microscissors, I carefully removed a tiny piece of tissue, approximately 2 millimeters square. The moment I cut into the wall, the fluid inside began moving more rapidly, and the electrical discharges became more frequent and intense. Something else happened that I still cannot explain. As soon as I removed the tissue sample, Patricia's EEG monitoring, which had shown normal anesthetic patterns throughout the surgery, suddenly displayed a burst of organized electrical activity that Dr. Morrison described as unlike anything I've seen in 15 years of neuroanesthesia. Her brain activity just spiked dramatically, but she's still under deep anesthesia, Dr. Morrison reported. Blood pressure and heart rate remain stable, but these EEG patterns, they look almost like REM sleep patterns, but far more organized and complex. I placed the tissue sample in formalin for pathological analysis and continued examining the chamber. Using a micro-Doppler probe, I attempted to assess blood flow in the surrounding tissue. The results were impossible. The probe registered blood flow patterns that suggested the chamber was somehow connected to Patricia's circulatory system, but in a configuration that violated everything I knew about cerebral vascular anatomy. The chamber appeared to have its own blood supply, with tiny vessels that branched in patterns unlike any normal brain vasculature. More impossible still, the Doppler indicated that blood flow through these vessels was running in the opposite direction from what physics and physiology demanded, flowing upward against gravity and pressure gradients. At 3:23 p.m., I made the decision that would haunt me for the rest of my career. Against every instinct and all surgical protocols, I attempted to remove the chamber intact. I felt compelled to understand what we were dealing with, and removing it for complete analysis seemed like the only way to get answers. As I began dissecting around the chamber, separating it from surrounding brain tissue, Patricia's vital signs began changing in ways that made no medical sense. Her heart rate dropped to 45 beats per minute, but her blood pressure remained perfectly stable. Her oxygen saturation held steady at 99%, but her end-tidal CO2 readings began fluctuating in a rhythmic pattern that matched the fluid movement inside the chamber. Most disturbing of all, her EEG patterns began showing what Dr. Morrison could only describe as organized, complex activity, despite her being under deep general anesthesia. The patterns weren't consistent with any known state of consciousness, yet they showed clear organization and structure. "Dr. Hayes," Jennifer said quietly, "her eyes are moving under her lids. Rapid, organized movements, like she's tracking something." I looked up from the microscope. Patricia's closed eyelids were indeed showing rapid, purposeful movements, as if she were watching something in a dream. But the movements were too organized, too deliberate for normal REM sleep, and they shouldn't have been occurring under general anesthesia. At 3:31 p.m., I successfully separated the chamber from surrounding tissue. The moment it was completely free, several impossible things happened simultaneously. Patricia's EEG suddenly showed a brief burst of what could only be described as hyper-organized brain activity, patterns of electrical activity more complex and organized than anything recorded from a conscious human brain. The activity lasted exactly 7 seconds, then returned to normal anesthetic patterns. The chamber itself, now removed from Patricia's brain and sitting in a specimen container, continued to show the internal fluid movement for another 43 seconds before becoming completely still. The electrical discharges across its walls gradually diminished and stopped. Most impossibly, Patricia's post-removal MRI, taken 4 hours after surgery, showed no evidence that anything had ever existed in the location where we'd found the chamber. The brain tissue had somehow reorganized itself perfectly, with no surgical cavity, no scar tissue, and no signs of any previous abnormality. It was as if the space the chamber had occupied simply closed seamlessly behind it. The pathology report on the tissue sample came back 3 days later. Dr. Elizabeth Santos, our chief pathologist with 30 years of experience, called me personally to discuss the results. "Robert, I've analyzed this sample 6 times using every technique available. The tissue contains cellular structures that don't match any known human tissue type. The cells show characteristics of neural tissue, but they're organized in patterns that don't exist in normal human anatomy. Most problematically, some of the cells appear to be metabolically active despite being removed from the body 3 days ago." I asked her to elaborate on metabolically active. Under electron microscopy, we can see cellular processes continuing, mitochondrial activity, protein synthesis, even what appears to be cell division. "Robert, these cells shouldn't be alive. They've been in formalin for 3 days. Nothing should survive that preservation process, yet these cells show signs of active metabolism." Patricia's recovery was flawless. She woke from anesthesia with no neurological deficits, no memory of the procedure, and complete resolution of her preoperative symptoms. Her headaches were gone, her vision was normal, and her cognitive function was perfect. She was discharged 2 days later with no complications, but the case consumed me. I spent hours reviewing the surgical video, analyzing every detail of what we'd encountered. I consulted with colleagues across the country, describing the case without revealing patient information. Every neurosurgeon I spoke with insisted that what I was describing was medically impossible. 3 weeks later, I encountered a second case with disturbing similarities. A 43-year-old man named Thomas Reed presented with symptoms identical to Patricia's: severe headaches, visual disturbances, and episodes of altered consciousness. His MRI showed a similar mass in the right temporal lobe. During surgery on November 8th, I found another chamber, nearly identical to Patricia's, but slightly larger, measuring 2.1 centimeters in diameter. This time, I was prepared. I brought Dr. Fisher into the OR as a primary observer, and I arranged for comprehensive monitoring and documentation of everything we encountered. The results were identical. The chamber contained flowing fluid, showed electrical activity, and appeared to have its own vascular supply with impossible blood flow patterns. When I removed it, Thomas showed the same burst of hyper-organized brain activity, and his post-operative MRI showed perfect tissue reorganization with no evidence of the chamber's previous existence. The pathology results were identical to Patricia's case: metabolically active tissue that defied classification and continued showing signs of life days after removal. 2 weeks after Thomas's surgery, a third case appeared. Margaret Foster, a 35-year-old attorney with identical symptoms and imaging findings. I found myself facing the same impossible structure for the third time. By this point, I had documented everything meticulously: high-definition surgical video, comprehensive pathological analysis, detailed pre- and post-operative imaging. I had enlisted Dr. William Park, our Chief of Radiology, to conduct detailed analysis of all imaging studies. His conclusion was that the post-operative scans showed complete tissue reorganization that violates known principles of neuroplasticity and healing. I consulted with Dr. James Richardson at the Mayo Clinic, considered one of the world's leading experts in unusual neurological presentations. After reviewing all documentation, his response was simple: "Robert, if I hadn't known you for 15 years, I would assume this was an elaborate hoax. What you're describing cannot exist within our understanding of human neurobiology. But the most disturbing aspect wasn't the medical impossibility of what I was finding. It was the pattern that emerged when I analyzed all 3 cases together. Patricia, Thomas, and Margaret had more in common than just their symptoms. All 3 were creative professionals. Patricia was a graphic designer, Thomas was a freelance musician, and Margaret specialized in creative writing for legal publications. All three had experienced the onset of symptoms approximately 6 months before surgery. All three lived alone and had no significant relationships. Most unsettling, when I discreetly contacted all three patients during their post-operative follow-up visits, each described the same experience: vivid, recurring dreams that had begun around the time their symptoms started. They all described dreaming of a place that felt more real than being awake, and reported that since surgery, they no longer experienced these dreams and felt like something important had been taken away. I began losing sleep, obsessing over these cases. I researched everything I could find about unusual neurological structures, developmental anomalies, and rare brain formations. Nothing in medical literature came close to explaining what I had encountered. The breaking point came during my fourth similar case on December 3rd. As I approached the chamber in 49-year-old Sarah Mills's brain, something unprecedented happened. Before I even touched the structure, it began pulsing more rapidly, and the electrical activity across its walls intensified dramatically. Sarah's EEG monitoring showed the same hyper-organized brain activity, but this time it occurred while I was still dissecting toward the chamber, before any direct contact. It was as if the structure somehow sensed my approach and was responding to my presence. I completed Sarah's surgery, but the experience shattered my confidence entirely. I found myself unable to concentrate during subsequent procedures, constantly questioning my perceptions and doubting my surgical judgment. During a routine tumor removal on December 10th, I became so distracted wondering if I might encounter another chamber that I nearly made a critical error that could have cost my patient their life. That night, I made the decision to resign. I couldn't continue practicing neurosurgery while harboring doubts about the fundamental nature of human neurobiology. If these chambers could exist undetected until surgical exploration, how many other cases might have involved similar structures that were removed without recognition? How many tumors had I removed over 22 years that might have been something else entirely? The tissue samples from all 4 cases remain in our pathology department, still showing metabolically active cells months after preservation. Dr. Santos has consulted with pathologists at Johns Hopkins, Mayo Clinic, and Massachusetts General. None can explain the continued cellular activity. I submitted my resignation on December 15th, effective immediately. My colleagues assumed I was suffering from burnout or stress-related decision-making. Dr. Fisher will assume my position as interim chief while the hospital searches for my replacement. The 4 patients, Patricia, Thomas, Margaret, and Sarah, all remain symptom-free, with no neurological deficits. Their post-operative scans continue to show perfect brain tissue organization with no evidence of surgical intervention. To any outside observer, their surgeries were complete successes. But I know what I found in their brains. I know what I removed. And I know that current medical science has no explanation for any of it. I often wonder about the dreams my patients described losing after surgery. What were those chambers? Why did they develop in creative individuals? What function might they have served? Were we removing something beneficial that we simply couldn't understand? In my 22 years of neurosurgical practice, I believed I understood the human brain as well as anyone could. I was wrong. The chambers I encountered suggest that human neurobiology may be far more complex and mysterious than we realize. I've started work as a medical consultant for a research company, reviewing cases and analyzing unusual presentations. It's safer work, with no direct patient care responsibilities, but I find myself scrutinizing every neurological case that crosses my desk, wondering what other impossible structures might be waiting undiscovered in human brains across the world. The chambers are still out there. In how many other patients are similar structures developing, undetected by current imaging technology? How many other neurosurgeons might encounter what I found and dismiss it as a surgical anomaly rather than documenting it properly. Sometimes I wonder if walking away was the right choice, or if I should have stayed to investigate further. But I couldn't continue operating on patients while questioning the very foundation of everything I thought I knew about the human brain. The most terrifying realization isn't that these chambers exist. It's that they suggest human consciousness and neurological function may operate according to principles we haven't even begun to discover.